Hello everybody, Dean Whiting from Pathology Technology Australia, and this is the third in our COVID mini-series featuring Professor Mary Louise McLaws, epidemiologist from University of New South Wales and World Health Organization representative for infection and detection of viruses. I get that wrong every time, but we know what I mean. So welcome, Mary Louise, and thank you very much for joining us yet again.
It's a pleasure to be with you.
And this time around, we thought we'd like to focus in a bit more on testing and how effective testing can help us manage COVID-19 in this sort of new COVID world. And we know that up until now, we've been monitoring infection in the community and counting the numbers of people in the community that have been affected. But we've now recently switched over to really monitoring how many people are ending up in hospital and in ICU beds. And we want to talk a little bit about the importance of testing in this sense. But first of all, I'd like to ask Mary Louise, in a workplace or a restricted or a confined environment, what's the way in which the virus gets around and can be transmitted from one person to the next?
Well, Dean, quite some time ago, leading up into the preparation of pandemic influenza, my PhD student, Dr. Jan Grolton, and Professor Bill Rawlinson and I looked at how people produce different size particles, or there was a belief that people who had flu only produced tiny particles called aerosols.
So these are little droplets that come from your mouth and nose, right?
Yes, and we call them aerosol particles or airborne because the droplets are, there's a classification of more than 5 microns is droplet, and smaller is airborne or small particles. So and we found that it was, after we did the study, of course, there was historical work. We're not the only ones to find this, but patients who had influenza A, B, RSV, and other viral infections all produced a mixed-sized particles. So to say that a disease is only droplet or only airborne spread is quite naive and fairly dangerous. Certainly, temperature and humidity and airflow will change the likelihood of whether you're going to get something by droplet or tiny airborne spread. And in fact, I was in Hong Kong for a meeting once. It was around about the pandemic influenza period, and the man at the time who was the chief infection control officer, I asked him, are you going to cancel the New Year?
Chinese Lunar New Year.
Chinese New Year, yeah. And he said, oh no, he looked up the temperature and humidity, and it was freezing cold. And he said, no, look.
Almost no humidity,
No humidity. So it's only droplet size and they'll fall to the ground. It's freezing cold out there. They won't get, strangers won't get too close. And he didn't have any additional spread of influenza. So we've known this for quite some time, and COVID is no different. It can be spread by tiny particles, and if you have poor airflow change, then it's more likely that those particles will build up. And we've seen it in quarantine hotels, particularly that dead space in the corridor. And then, of course, if you open up your door to collect your food or to be tested, you can cause a positive airflow change either way. And if it builds up in the corridor and you've got a staff member in that corridor who may inadvertently take their mask off and put it under their nose, then that can build up and the next person that opens up the door can get a faceful. So certainly airflow, temperature, humidity are all really important.
And that sort of explains why what we're seeing in cold chain distribution centres, in meatworks, in places where people work close together, where it's usually pretty damp or humid. That's why we see these so-called super spreader events where many people in that particular confined space or in that workspace develop COVID very quickly. And I guess that's one of the reasons why we're really advocating very strongly that in at-risk locations such as aged care, healthcare facilities, in essential workplaces such as in food distribution, in food preparation centres, we should really be testing on a high frequency basis. And I think, Mary Louise, the recommendations have always been, testing probably every 2 or 3 days of the workers in these locations, isn't it?
Absolutely. And look, this isn't unusual. We've had these outbreaks in the US and Germany and several times in Victoria. So we really do need to test people. If they're not going to be a high number of changeover of staff, then you could do, if they're all full time, you could do every other day. Otherwise, I think if you've got a high level of casual staff, it's very difficult for the authorities to work out who should be tested when. So they'd have to keep very good records. And in that way, you'd need to test probably every day to ensure that those who didn't work yesterday are getting tested again.
Yeah, and I think that's the way we're seeing it develop now. The Commonwealth Government has funded a pilot program using rapid antigen testing in aged care facilities. And I think there's somewhere between 500 and 700 aged care facilities now in which anybody going into the building on any given day will have that 15-minute rapid antigen test. A negative result means away you go. A positive result means you go to a follow-up PCR test. I mean, we both know Dr. Ian Norton, who is on behalf of the Commonwealth running those aged care facility tests. I'm told by Ian that this was a week or two back now, but they detected, I think, 7 or more cases already where they've been able to stop people going into these aged care facilities. So I think it's proof positive that this kind of approach will work well. And go ahead.
May I say, Dean, that is absolutely true, because don't forget staff often work across several
Yes.
campuses because they don't get enough pay to just stay in a single campus. But the New South Wales Health put out weekly reports, and from these weekly reports, you can see that healthcare workers, of the 200 that were identified as being positive who acquired it in the healthcare facilities, 40% of them, that is 80, were fully vaccinated, and 11%, 22, were partially vaccinated. So we do still, until we get those booster shots and until we have really low circulating viral numbers, we really do need to continue to test healthcare workers and care staff.
Oh, absolutely. And in essential workplaces, I know one very large grocery chain has commenced a number of months ago now, had commenced testing everybody going into their main warehousing and distribution services. They're now up to about 600,000 tests at these facilities. It's amazing. They test everybody before going into work. Of those people going into work over this period of time, they've not had a single shutdown, despite the fact that before they started this testing program, they'd had to shut down a number of these facilities a couple of times. And you can imagine Australia's food distribution being shut down for any length of time could potentially have major impact on people's food supplies. But since introducing the testing every day, they've detected 270 odd positives by rapid antigen test, which were then sent on for confirmation. Of those, I think around 74 have come back as positive to PCR. So that's 74 occasions on which an infection could have got into a critical workplace affecting Australia's food supply, and that's been prevented. And since then, since they've commenced this, not a single shutdown in any of these facilities. So I think that's proof positive now, isn't it, that we do need to be doing this kind of thing, even though we have good vaccination rates. We still need to have this testing program.
People who work in aged care can acquire infection both at work or in the community. And so from the 16th of June until the end of November, New South Wales identified, 325 aged care workers as positive, and over 150 of them acquired it, not necessarily at work, but out in the community. And so therefore you really do need to test people, even if they have been vaccinated, because 40% were about 40% were fully vaccinated. And so it's really important to still test and not always assume if there was an outbreak in residential aged care, you then do the testing, because people could have acquired it in the community. And the same for the healthcare workers as well. Of the 1,045 infections in healthcare workers in the community and those that were not linked to anything in particular, there are about 840 odd of them. So it really is important to still remember that of them, 40% were fully vaccinated. So you do need to test all the time, particularly with that high circulating infection rate and having had the vaccine for quite some time. You still need to test, because you can't assume that everybody's covered because they've been vaccinated.
But the model is able to be used now to say, okay, for a workplace of 50 people, a single work site of 50 people, if you don't get the testing, and you get an infection at any time over the next 28 weeks, which when you think about it is highly likely, it could cost the organisation between $300,000 and $400,000 to shut down. Yet testing on a regular basis for rapid antigen testing might cost well less than $100,000. So this economic model helps you understand what the cost of testing is, but more importantly, what the cost of not testing is. And you can dial in any range of number of people working, from anywhere from 5 up to 5,000 if you wish, at a single site. So I think the model's quite helpful, and I'm more than happy to share that with any business that's interested. They just need to contact me. And I think let's round this out by saying, what are the two most important things we can do between now and maybe the middle of next year, once we should have most things sorted out here? The two most important things we can do. One is get the booster.
And two is get tested.
Get tested. So I think that's pretty simple. I think just always get tested if you feel any symptoms. Encourage your workplace to test you prior to going into work. Maybe get some tests from the pharmacy or from the supermarket and test before you go to a big event. That all of those would be effective ways of getting tested. So it just remains for me to, Mary Louise, thank you so much for you lending us your expertise here. We enjoy so much hearing the up-to-date information from you, and thank you very much on behalf of all our members. And so long for now.
Thank you.
Stay safe.
Stay safe.